Hello, everyone, and welcome back to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier, consisting of review articles centered on a major topic important to surgical oncologists. I'm Megan Ashdown, managing editor of the series, and today we'll be discussing the October 2025 issue dedicated to lung cancer. Leading the conversation is our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of this issue, Dr. Daniela Molina, director of esophageal cancer surgery program at Memorial Sloan Kettering Cancer Center in New York, New York. Welcome, and I'll now turn it over to you, Dr. Pollack.
Thank you, Megan. Dr. Molina, welcome. We are so excited to be here with you today. Thank you so much for guest editing this wonderful volume of Surgical Oncology Clinics and for joining me today for this podcast.
My pleasure. Happy to be here.
Well, we're lucky to have such an international expert with us today. I thought maybe what we'd do is go over four papers from this volume. You know, all the papers are so amazing. We could have chosen any of them, but the first one I wanted to maybe just talk a little bit about is the paper by Chang and colleagues on diagnosis and staging lung cancer with modern tools. There's been so many advancements with regards to cross-sectional imaging, functional imaging. I was hoping that you could maybe tell us a little bit more about, what are some of the modern tools to diagnose or even screen nowadays patients who may have a suspicion of a lung cancer.
Yeah, I think that the best advantage that we have today is that we have screening that is approved for all smokers that has significant smoking history, and they can have a CT scan, and we can find these nodules that can be really small sometimes, and we can follow them if we think that they might become or already have harboring some cancer cells, but also we can find cancers at a time when they're curable. And so that's the biggest advantage. And now we have a lot of sophisticated tools that can help us to make that diagnosis. We can definitely use old technologies like CT scan and PET-CT scans, and those help us to determine which nodule are more at risk than others. But then the final diagnosis is a biopsy. And so, the old way to obtain a biopsy is basically having the patient on a scanner and have a needle going into the nodule. But now actually we can navigate through the airways. Like think about the airways as a tree trunk with all the branches. And we can go right in the lungs of the patients and navigate and obtain biopsy of these nodules, even if they're multiple and diffuse in different lobes. And at the same time, we can also get biopsy of the mediastinal lymph nodes, which are the most important factors for staging of lung cancer in general. So these are really a lot of new tools, and we can really reach small little nodules throughout the entire lungs. And sometimes we mark them because, if you want to resect them and remove them, they're so small, sometimes we cannot find them surgically with all the new tools that we have with robotic, resection and so forth. So we can mark them either with dye colored or with other, little pieces of metal that we can find that during the surgical procedure.
So as a non-thoracic surgeon, I'm often faced with someone shows up and they may have a cancer in the pancreas or the colon. They have this nodule in the lung.
Yes,
and,
right.
It's always challenging sometimes to figure out, is it real? Is it not real? Should we biopsy? Should we not biopsy? And so I'm wondering if you could just help us better understand, what's your threshold for biopsying something and like how small can it be? And if it's peripheral, you're more likely to do a needle biopsy. And if it's central, you're more likely to do an endobronchial biopsy. Could you help us a little bit with that?
Yeah, well, today, AI and hopefully some of the radiomics information from multiple, scans that have been seen over the years can help really to pinpoint the risks of a nodule to be cancerous or no cancerous. So we can do a little bit of that clinical evaluation. We can look at PET scan and looks at the metabolic activity of a nodule. That will help us. And then sometimes we just need, as you said, we need to know what it is because we have other cancers that we need to treat, and we want to know if there is nodule that are significant or not significant. So the nodule, can be even very small today for obtaining a biopsy. And the old rule that centrally located can be reached with bronchoscopy and peripheral better treated with the transthoracic approach. I think that's an old paradigm because now with the robotic bronchoscopy, we can really reach very peripherally located nodule, even through the navigation of the airways. So that rule is a little bit not so common anymore. My decision, I look at the location, I look at the size, I look at the characteristic of the node. And also I look if there is any bronchus near the node so that we can navigate easy to it. And then, the risk factors, right? A patient smoker or non-smoker, exposure, secondhand smoking, and then genetics. I think a lot of that is also a risk factor in terms of predisposition. All those factors, so you kind of put together and you come up with a decision algorithm when that is worth to get a biopsies or not.
So that's helpful. So in addition to possibly biopsying the lesion, maybe you could discuss a little bit, what is the full staging workup of the patient that will help you decide, as we're going to, segue into the next paper around perioperative care, what information do you want to know with the clinical staging to help you decide on your next therapeutic steps? Can you walk us through that? When do you use a PET scan? When do you maybe look for disease outside of the thorax, metastatic disease? When do you biopsy the lymph nodes, et cetera?
Yeah, so there are nodules in the lung that we now find that are called ground glass opacities. Those can be cancerous, but often they're really very indolent and do not represent a major, advanced disease. So we really look for nodules that are more solid and nodule that are PET avid. So if you have a high SUV, the metabolism of that nodule is higher. So the differentiation is not as good and the nodule is growing faster, right? And so those are all characteristics that are important for us to determine. But then, so if you have a solid nodule that's larger than a centimeter, we definitely get a PET CT. If the PET scan has a high SUV, we look for lymph nodes involvement. And for any nodule that is more than 2 centimeters in size or has a high SUV uptake more than 4, we suspect there might be positive lymph nodes. Even if they're PET negative, then we recommend doing an endobronchial ultrasound to really look at those lymph nodes and biopsy them to exclude even a occult positive nodal disease, because that is treated completely different. And then we look, of course, all systems. So lung cancer can metastasize to the lung, to the lymph nodes, to the brain, to the adrenal glands, the liver. So all other organs are really evaluated with a PET scan or with a brain MRI. So we are pretty aggressive with staging because there are a lot of options for treatment now that are more multidisciplinary that can really increase the rate of cure of the disease.
So that's a perfect segue. Thank you so much, Dr. Molina, for going through that. So now after you've staged the patient, and here we're predominantly talking about non-small cell lung cancer, can you help us understand a little bit about this multidisciplinary management, about the perioperative management? Who might you take directly to the operating room versus someone you might give neoadjuvant therapy to? So help us understand, how that conversation unfolds with your multidisciplinary colleagues and the patient.
Well, today I think it's an exciting time for lung cancer because we have a lot more drugs that actually work, right? In the past, we only had chemotherapy and often didn't really work so well. So now that we have a different type of approaches to lung cancer, we still have chemotherapy, which definitely helps, but we have immunotherapy, right? We'll help the patient's immune system to respond and attack potentially the cancer. And then we have targeted therapies. Those are treatments that can basically attack a specific genes within the cancer. So there's a lot more options that we have for this disease today. And my take and my approach is if the patient would benefit from some form of systemic treatment, I prefer that the patient gets it upfront. It is a lot easier to receive your systemic treatment when you're healthy. You don't have to deal with pain related to surgery. Unfortunately, we do create some pain with our operations. And then if there are any complications during surgery, then the treatment is delayed because patient has to be in a good shape to be able to tolerate it. So my approach is if yeah, I think the patient will need systemic treatment combination, which is usually for cancers that are larger than 4 centimeters in size or have any nodal disease involved. Then I prefer the patient gets treatment up front. Also, with these new drugs, these immunotherapy agents, they seems like to work better when the tumor is in place. They almost like prime themselves, right, to respond to the tumor in a more effective way if the tumor is still present in the body. So I prefer to give patients a treatment before taking them to the operating room. Of course, if there is any issues with not tolerability to treatment, or the tumor is still kind of only with nodes within the lung tissue or close to the lung cancer parenchyma, then you can still do surgery up front. But we do it less and less these days. We prefer to do combination treatment. We discuss this patient our thoracic tumor board so that everybody kind of has the opportunity to discuss it and put their input.
So that's great. So how long typically does that preoperative chemotherapy last? We talking 2 to 3 months of chemotherapy? And then is there ever a role for neoadjuvant radiation? I know that was briefly brought up in the article by Dr. Worrell and colleagues.
Yeah, so we used to do a lot more neoadjuvant chemotherapy and radiation. I think we do a little bit less. The radiation piece now is more reserved for patients that we don't think we're going to be able to operate. And so there are still patients that have extensive disease. They go to places like the trachea or the aorta or other organs that we cannot resect. That we prefer to treat them with a combination of chemotherapy and radiation. Surgery really is not an option for those patients. But if we think patients are operable, we use mostly now a combination of chemotherapy and immunotherapy, and we do about a couple of months of treatment. And then we restage the patients to make sure that there was no progression of disease. And then we decide to operate on them. Sometimes we have amazing responses, and we think actually that the tumor is all gone. They start to tell preoperatively. We know after the tumor is removed that the tumor is all dead in their lungs, and we are very happy with that responses. But I think the future, is going to be like really more effort in deciding and understanding, which patient really needs surgery after a very successful treatment. And then we have those patients. There is actually a chapter on this on the book, looking at those borderline resectability, right? Those patients that we're not sure we can resect them, and
Sure.
sometimes we have been able to salvage, right, to say, okay, we give them treatment, we see how they do, and they have a great response. We're able to still operate them after treatment, or if they don't respond, well, they still have the option of the radiation. So it's a lot more complex than it used to be, but I think a lot more options for patients to be cured from that disease.
Yeah, definitely an exciting time, and lung cancer and other cancers with all the targeted therapy that's now available. So we give the preoperative therapy, and now we're at surgery. So maybe we can
Yes.
talk just a little bit about surgical resection. Again, as a non-thoracic surgeon, can you take me through this as far as lobar, sublobar, the
Okay.
importance of margins, margin width? How do you approach it as a surgeon, depending on where the lesion is, how big the lesion is, etc.?
Yeah, it's become a lot more complicated in that sense too. For early stage disease, actually, we thought that for every cancer we take the lobe out, and that's kind of old news. Now we do a lot more sublobar resection, whether it's a segmentectomy or a wedge resection for tumors that we think are low risk. So smaller than 2 centimeters, they're not really PET avid, that they have some ground glass component to them. They're good randomized clinical trials that have shown that there is no difference in outcome, and potentially you can spare some lung so the patient can have, a better ability to exercise. And also, in the future, if more cancer come up on these patients, we have more options for treatment. Now, when you have Patients that have more advanced disease, that we treat them with the neoadjuvant treatment with chemo or immunotherapy. Then, like the standard of care would be to do a lobectomy, although there's a lot yet that we don't know. Like we have amazing responses. And so, like I've had situation where you have to think a little bit outside the box. You might have a patient with two cancers on both sides of the chest. And one cancer more advanced has a great response. Well, do we need to remove the entire lobe? That is, something that at this time we don't advocate for not doing it, but I'm sure that in the future we know more and more. And if you have an amazing response, and we think maybe even a complete response within the lung, maybe just removing that lung with a wedge resection or with a segmentectomy might be appropriate and enough for curing. And so that patient have more lung to be handled, for other cancers that might arise or they already are present. Because unfortunately, this disease, sometime, once you have the risk factors and you have the genetics, unfortunately, we see a lot of synchronous or metachronous cancers.
That's great. So I wanted to move on to an article that I found was really interesting. The one that you wrote with your colleague, Dr. Sewell, on the treatment of lung cancer in women. As most of us know, the actual incidence of lung cancer in men has been decreasing, but it's actually increasing in women. So I wanted to take some time to chat with you about that, maybe provide us some insights, first of all, around the epidemiologic phenomena of increasing lung cancer in women and in non-smokers. And then, maybe share with us a little bit how lung cancer is different in women, both from a molecular point of view and perhaps from the way you approach it therapeutically.
Yeah, so that's a subject that is very interesting to me because, when you think about lung cancer, you always think about men with lung cancer, but actually we see so many women now with lung cancer. I don't know if for sure there is a difference in epidemiology of the disease, but I think there might be a difference in terms of sensitivity to risk factors. And so, like a lot of the women that we see with lung cancer will never meet criteria, for example, for screening. And so that you'll never find that cancer when it's an early stage that can be cured. Luckily, women have other diagnostic tests that they go through for breast prevention and so forth, and we can find this cancer really early stage. There is also a group of women that have never smoked that now we see with lung cancer, and there's a lot of those women that have Asian descent, and they have tumors that are more genetically determined, so they have a lot of targets within the tumor itself. Like the most common is EGFR mutant cancer, and we see that very commonly in women of Asian descent. We don't really know what the cause of that is and how we can prevent that, but it's something really that is important to keep in mind because there are now, trials to develop screening specifically for that population, but it's also important to keep in mind so that we can continue to diagnose these patients at early stage. Interestingly, women do a little bit better than men overall, even when we match stage by stage disease. So it's not just a factor of that women may be diagnosed earlier with the more, benevolent disease, if you want. But I think that women in general may be healthier. So there is less cardiovascular disease, there is less comorbidities within women that may allow them to be treated a little bit more, aggressively and with better outcomes. And so that's a very interesting point, is that maybe estrogen protection with women that men don't have, that allow us to have a better outcome overall with women. But it is definitely an issue that it's as you said, lung cancer in women is increasing, maybe because also of secondhand smoking and the exposure from men that smoke, and maybe women are sensitive enough to just secondhand smoking to develop lung cancer. So a big field, I think, for us to learn more and to investigate.
One thing I thought was interesting, you mentioned that women prognostically may do better, but you highlight in the article how women may experience greater toxicity from systemic therapy. Could you briefly just touch on that? Is it all systemic therapy? Is it certain systemic therapy? Any insights around that?
I mean, as you may know, often, women are the caregiver. Women are the one that take care, the kids or the elderly. and so maybe they don't really take care of themselves mostly. So what happened is that women might have all the data that we have on clinical trials are in male. So women are not really well represented in all the clinical trials that have told us, how well these new drugs can do with patients. And so we are actually looking at, for example, the effect of immunotherapy in women. And that effect might be very different than for men. And maybe it's the size of a woman, maybe it's like, the woman usually is smaller than a man, but also there are other factors that might influence the efficacy of drugs on women compared to men. And so that's a field that we're investigating right now.
Thank you. Well, the final article I wanted to touch on today is maybe a little bit even more provocative, is this notion of surgery for stage 4 disease. I frequently say that we used to think that the medical oncologists were going to put surgeons out of business as the chemotherapeutic drugs got better. We would have fewer people to operate on, but paradoxically, maybe we have more people to operate on, because as we better control systemic disease, we have greater indications for operating on patients with stage 4 disease. So I was wondering, can you just shed a little bit light of like who are candidates who have stage 4 disease, with regards to oligometastases? Is a certain number of metastases that are, or location, that there are certain locations that are deal breakers compared to other ones that are not. And then how do you manage those extrahepatic sites? Is it always with resection? Was it with chemotherapy? Or even is it with radiation therapy to control the disease?
Yeah, that's a very good question. I can talk for a long time about this, but I'll try to keep it brief because as you're right, we have better drugs, we do a better job, and we don't give up. We want to cure patients. And so there are patients that a diagnosis they have stage 4, right? So they might have a lung cancer with a brain met, for example, or a lung cancer with the adrenal met, and no other disease anywhere else. So that would be, an oligometastatic situation where you think that the cancer has spread, but still in a phase in which the metastatic portion can be contained. And so in those patients, we're very aggressive. We treat them with systemic disease. We stage them, the mediastinum, to make sure that what we see is not just the tip of an iceberg. There is more disease that it's not really well defined on imaging. But then we treat them aggressively. And then there are other patients that we see more often that I think are more rare today. And I'm not saying this is standard of care yet, but I think we'll see more and more, local treatment of their metastasis. Those are patients that are diagnosed with extensive disease. They might be like patients that have, like bone mets or brain mets, or like extensive disease that had either a targetable mutation. So we see a lot of different targets now, not just EGFR and ALK and ROS and other type of targets. And they have responded so well to the systemic portion of the disease, but they still have one side of disease. Sometimes it's the lung, but sometimes it's a metastatic site. And we go after that either with surgery, but no, you're right, not just surgery. Sometimes surgery would be too devastating, right? And we prefer to do radiation, or impossible. If it's a bone mat that is not resectable, radiation is very effective. Or ablation. Ablation is another tool, that we are using more and more in this kind of metastatic setting. And so those are situations which you would never think those patients are curable. And now all of a sudden they come back to your clinic to say all the rest of their cancer is gone away, but they do have, this area of disease, and could we treat them locally? And then there is the other group, patient that you already treated them, you thought they were cured, and then boom, something come up, right? So it's oligometastatic progression. And again, you always want a discussion and a multidisciplinary team, because you want to have all of the tools available. You want to look at the specific of the cancer, the genetic informations, the biomolecular markers, and then make a decision altogether, how about what to do. And sometimes we go directly just to treat the metastatic site alone. And sometimes we decided that patient might benefit better for a systemic treatment first, to let the disease declare itself, and then go after the metastatic site when we know that there's nothing else really to worry about. So a lot more paradigms here. No standards, I guess, and a little bit ability to think out of the box with this disease.
That's great. Well, thank you so much, Dr. Molina. I think all of those comments just highlight, all the exciting things that are happening in this field, whether it be the advances in systemic therapy, targeted therapy, immunotherapy, or the robot and its ability to make these procedures less morbid for patients. This issue really just highlights, so well for our readership, all the advances in lung cancer. So I'm very indebted to you for your leadership of the volume and all of the wonderful internationally renowned co-authors who contributed articles. Thank you again for your time today. I just want to express my gratitude. So thank you, Dr. Molina.
Thank you so much, Dr. Polly. It was a real pleasure to participate and to get all of these amazing authors together to hopefully give some value, to all the patients and physicians and anyone out there that is trying to improve this field.
Great. Thanks again.
Thanks again for joining us for this episode of the Surgical Oncology Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on lung cancer, please visit us.elsevierhealth.com/expert. Surgical Oncology Clinics is available for individual print subscriptions with online access or as an online-only subscription. The series is also available via Elsevier's electronic platforms, Clinical Key and Science Direct. For more information about this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Don't forget to follow us on LinkedIn at Clinics Review Articles and subscribe to the Surgical Oncology Clinics podcast. Thanks for listening.